Fighting Blindness Canada's Viewpoint is an education series that brings you the latest in vision research presented by health experts from across Canada. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly presented by Bayer and supported by Abbvie, Apellis, Astellas, Beacon Therapeutics, Biogen, Johnson & Johnson, Novartis, and Roche. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
Dr. Sharma Ortz is an assistant professor in the Department of Ophthalmology at Indiana University School of Medicine and is also the Director of Diversity, Equity, Inclusion, and Justice for her department. She is passionate about the scientific exploration of pressure-induced neurodegeneration, targeting neuronal cell death pathways, and generating pluripotent stem cells to model diseases. And so she's going to be talking about some of her research efforts that she is committed to, and she hopes will drive interventions that can improve public health care. So welcome to the program, Taz. How are you doing?
Pretty good. How are you today?
Very good. Yeah, we're sort of neighbors here because I'm also in Chicago, so much closer to you than we normally are. So to kick off the session, just for a little bit of level setting, because we're going to be talking about optic nerves. So I was wondering if you could tell us a little bit about sort of what the optic nerve is, how it's affecting glaucoma, why this is important.
Yeah, so my lab, actually, we focus on retinal ganglion cell, de novo generation of retinal ganglion cells in the lab. But to backtrack, basically, and to answer your question, it is the connection. The optic nerve is actually the connection from the eye to the brain. So the terminal neurons of the retina, which is the retinal ganglion cells, make the connections or perceive the light that comes through the photoreceptors and transmit those signals to the visual centers of the brain. And the way they do that is like conduits, of axons. So those axons transmit those visual signals, and the optic nerve is made up of those axons from these retinal ganglion cells. But in glaucoma, and there are multiple types of glaucoma, and it's a multifactorial disease where race, genetics, a lot of things are in play. But one of the aspects or one of the major risk factors in glaucoma is intraocular pressure. So, when you go to the eye doctor or an eye checkup and they do that puff of air kind of test, they're measuring pressure within the eye. And once your pressures are high, which is one type of glaucoma or primary open angle glaucoma, then they will dilate your eye, look at your fundus, see if there is optic nerve degeneration. And what they mean by that is these retinal ganglion cells start dying in glaucoma. And as they start dying, because of the pressure within the eye, the most sensitive part of the eye is these cells making these right angle turns to go to the brain. And so that region within the eye or at the optic nerve head, which makes the optic nerve starts getting damaged. And so there's gliosis, scarring happening at the optic nerve head within the optic nerve, and that eventually causes these retinal ganglion cells to die. And so our lab is focused in not only making new optic nerve, retinal ganglion cells, but also how do we make sure that there's regeneration happening, or that the cells that are remaining in the retina, how can they survive? Could we put in neurotrophic factors? Could we do other sorts of therapeutics or strategies to make sure that we can preserve visual function?
And so, yeah, for some of the audience members, like something that I only learned when I joined Fighting Blindness Canada is that when optic nerves are damaged or die in glaucoma, it actually is irreversible. So currently there's no way to, even if you're taking drops, you can help slow progression, but you're not going to be able to bring back the sight that's lost. So that's why the regeneration is so important. I was also wondering, and I'm not sure if it's known in the field why this happens, but why does the high pressure specifically impact the optic nerve and not other cells in the retina? Because you don't really hear like photoreceptors getting damaged, but it's very specifically about the optic nerve.
Yes, because as I was mentioning, the retinal ganglion cells are those last neurons. So light goes to the photoreceptors, then, there's 5 types of neurons in the retina, and it gets transmitted downstream to those retinal ganglion cells. Now, those retinal ganglion cells have those axons going out of the eye. And so that when the pressure happens, the most sensitive part where there's no scleral tissue or nothing is the little, blind spot, as we call it when we look at it. And that's where that optic nerve is, right? And so those ganglion cells are making these right angle turns to go down. So even on a wire, if you took a wire and made a right angle out of it and put pressure on that angle, the damage or the point of damage becomes that optic nerve. Okay. And when that damage starts or the pressure is so high, then when that starts happening, there's scarring, there's fibrosis, there's glial cells coming in, infiltrating. So a lot of other things are happening at that site of damage. And that's why when you hear about glaucoma, it's mainly ganglion cells dying and not the other neurons, because those are just making the interneuron connections to the ganglion cells, but the ganglion cells are the ones that have the axons going all the way to the brain. The other part of that question was also is that it slows progression of disease, but it does not reverse vision loss even with therapeutics. So the only modifiable risk factor right now is lowering intraocular pressure. The other risk factors, that is central corneal thickness, race, age, all of these things cannot be changed. And the one thing that we can change is intraocular pressure. And so when we lower the pressure, it slows the progression of disease, but the damage is still happening. There's still high enough pressure, sometimes either pharmaceutically through drugs or drops, they're doing that, or even surgically through interventions like trabeculectomies or things like that. But that pressure is not getting rid of the root cause of the problem. And the root cause of the problem are these retinal neurons dying. So how do we bring that back? And so there's two options, literally, right? Is that we minimize the pressure, which is what we're already doing. And we minimize the point of degeneration at the optic nerve. And we help the sick or the dying retinal ganglion cells from dying. And so the way we can do that, and which is a lot of labs work on that, is neuroregenerative therapeutics, where there's protection of the soma, and then there's protection of the axons. So even if there is glial scarring, if there is other things going on, can these axons still get past the gliotic site at the optic nerve and still keep, the sick or dying axons which have retracted those axons once they've started dying, can we regenerate them back? So that's one path of it. The other path is that when you have kind of end-stage disease, right? When most of the ganglion cells are lost, is there a cell therapy kind of thing where can we go in and transplant cells that can help revive some of the vision back? And so our lab works on both ends of that spectrum, right? Where when there's mild stage disease or moderate stage disease, could we have neuroregeneratives or neuroprotection plus regenerative therapeutics that can help these ganglion cells from dying? Or when most of the patients have their vision loss, where 10% of glaucoma patients become blind due to the disease, then could we go in and put in transplantable cells? And that is a huge feat in glaucoma as well, because these are central nervous system neurons, and peripheral nervous system has the capacity to regenerate, but not the central nervous system neurons, which is what the eye is a part of.
Maybe can you explain just like really briefly why peripheral nervous system can regenerate, and what's an example of the peripheral nervous system and why the central nervous system can't?
Yeah, so like sciatic nerves, like, other kind of nerves can regenerate, which is in the peripheral system. The central nervous system, which is your eye, your brain, your spine, those are more terminal differentiated neurons. They don't have the capacity to revive those retinal neurons. And most of it comes from inhibitory cues, or regenerative cues. So there is a lot more inhibitory cues in the central nervous system that prevents regeneration from happening.
So actually, like thinking about that, so maybe could you tell us a little bit about what are some of the strategies you're using to try to either sort of, I guess, replace the cells if they've already lost, or regenerate cells if they're still there but are a bit damaged?
Yeah, so what we do is we have a neurotrophic factor in the lab. It is called neuritin. We have a recombinant form of it, and it is soluble, secreted, a small protein. And so we are hoping when we put that protein in, all our retinal ganglion cells are not only surviving better. So the other part of it is it's really hard to grow adult neurons, central nervous system neurons, specifically retinal ganglion cells in culture. And so what we've noticed with this neuroprotection drug therapeutic is that we can keep the ganglion cells alive, we can help them regenerate. And even in mouse models, when we did the studies, and we put in the therapeutic as a gene therapy, it helped the ganglion cells grow past the gliotic site. So that's one aspect of it. And we also use a recombinant. So in my lab, I can actually grow human donor eyes in the lab in a perfusion system that allows me to keep tentatively alive these retinas over time in these posterior segment cups or donor eyes that we get from human donors. And then we can simulate pressures, so high pressures, low pressures. And then we put this drug in and see if we can keep the retinal ganglion cells alive for longer periods of time. The other aspect is that any donor eye that comes in through our lab, we can get their corneas or now even skin. So anybody's skin can be taken and we can make stem cells out of it. They're called induced pluripotent stem cells. And they're pluripotent. So what that means is that they have the ability to make other types of cells. So if you would like to make a retinal ganglion cell from it, you can. So we take these we take the corneas or the fibroblasts from all these donor eyes and we make them into their stem cells. And then after we make their stem cells, we can make little mini retinas in a dish in a lab. And then we take these mini retinas and we make retinal ganglion cells out of them. And so that is a strategy for us to see if we can do stem cell therapy based strategies. So that would be more for end stage disease. Mm-hmm. And then we also connect everything together where we take the human donor eye, put the neuroprotection drug in there, plus we do the stem cell derived retinal ganglion cell therapy and see under high pressures or normal pressures if these cells can even transplant. Because what if the microenvironment is so bad on a patient that has a lot of their retinal ganglion cells lost? If we try to transplant in that microenvironment, would they even integrate within the retina? Would they even be able to regenerate? Would they even be able to give the visual cues that we would like them to give? And that's a huge feat because when you're looking at it, the distances these retinal ganglion cells have to travel once they're transplanted is huge for them. So that's another aspect of it where we make de novo retinal ganglion cells in lab using stem cells.
So a couple of sort of follow-up questions to that. So you mentioned this neuroprotective factor. How did you maybe either find out about the factor? Is it a factor that's normally present in the eye or is it found in other parts of the body?
Yeah, so the factor actually, so it was discovered by Dr. Nadivi and all, by that group in 1997. And we came across it because we had these mouse models in the lab, and that was in my graduate school studies. So we took these mice and then we did a crush on their optic nerve. So basically we generated a glaucoma as kind of acute model system. And when we did the crush, we saw a lot of genes going up and down. And in this model that we were particularly doing, by 14 days, almost 70% of the ganglion cells die because the trauma is so significant. And in that acute kind of animal model system of glaucoma, if you can revive the retinal ganglion cells and help them regenerate past so the gliotic scar forms, everything forms. And so what we saw is at that 14-day point, there was a tipping curve. And one of the genes that was highly following the pattern of cell death was this gene called Neite. And so we got really interested in that. And then we found out that it's neurotrophic, neuroprotective, it protects the soma, it's regenerative, it's also got chemotactic potential. So basically, synaptic neurons can help it, and it travels down the axon and it can be secreted. So it has paracrine functioning. And there were multiple studies done in sciatic nerves and different other systems as well. And so then we looked at it in the retina. And so one of my papers from my PhD graduate studies was doing this crush and then using the gene therapy and seeing that, yes, it was going past the nerve side. But we also saw that human neuritin allowed these cells to survive better, even in cultures within the lab. So even though you have exotomized cultures, when you take these retinal ganglion cells from an adult retina, like a mouse retina or something, we were still seeing this neurite being able to help them grow and survive better. And so that's where our interest came about from that. And then we published the paper. And then since then, at that time, there was only 20 papers when I published on neurite, and now there's numerous papers on the trophic factor.
And I was sort of also wondering, because you talked a little bit about some of the challenges of getting, once you're trying to, say, if you're trying to put in new retinal ganglion cells, the difficulties in getting them to implant and to survive and to grow. I was wondering if you could talk a little bit. Sorry, there's a little bit of background noise. I can hear some things outside my door. Talk a little bit about where your research fits into the context of where other researchers are studying, because I'm sure a lot of researchers are studying similar problems, all trying to work towards being able to either restore retinal ganglion cells or help them survive better. So where does your piece of the puzzle fit in? What else is out there? What sort of big questions is the field trying to answer?
Yeah, and in fact, for the retinal ganglion cell field, we have in the US a Restore Consortium, which is part of a lot of international collaborators. And it's a consortium that's particularly looking at what every, vision researcher is doing at whatever stage, whether it's a graduate student, a postdoc, a medical student, clinician, clinical faculty. And it was initiated by the Johns Hopkins group and Dr. Tom Johnson is a part of that group. And, they initiated this whole consortium because the whole point was we all were working on little aspects of it. And as a field, we were not trying to see, there's so many difficulties associated with that, as you mentioned, right? Integration, transplantation first, integration. After integration, can they regenerate? Once they start making these neurites, can they actually form axons? Because we form neurites in the lab, but are they actually forming? Myelination could be integrated with oligodendrocytes. What if there is glial scarring? How do we counteract the inhibitory cues? So all those things came about. And so this Restore Consortium was born about a couple of years ago. And it's a consortium where we meet every 2 years at one of, just right before ARVO, which is one of our ophthalmology conferences that's highly attended by vision scientists across the world. And as an international conference. And so we meet before that, and then everyone gets together and talks about what they have learned, what they're doing, and how is the field coming together. So one of the things is maybe these ganglion cells, if you just put it as a bolus of injection, right, it may not transplant. Maybe they'll die faster. Maybe they need scaffolding, right? So they can be put on scaffolds and then be integrated. But if you were doing that, how would you integrate it within the inner retina? What are you going to do? What kind of surgical interventions would you need, right? Once they are integrated, would they make the interneuron connections to the amacrine or the horizontal or the bipolar cells, right? How are they then getting past that gliotic side? So every group has a little bit of different perspective from the glia side, from the ganglion cell side, from the induced pluripotent side, right? Or people who are working with fetal retinas. How does everything integrate? So it's a part of a big strategy, and the whole strategy is to cure vision at the end of the day.
Yeah, I think that's really wonderful. I was actually at ARVO this year, and I sat in some symposium where the group was talking about different aspects, and it was really interesting hearing from really sort of the discovery type science all the way to more translational work, how everybody was trying to work on little pieces of the puzzle. And I know we often get questions from our donors about, well, how do scientists know what other scientists are doing, and how do scientists make sure they aren't duplicating the work that's happening everywhere else? And I think your example is a really great example how scientists are coming together to discuss and ask questions and learn from each other, all sort of towards a bigger goal. I definitely want to leave room for some questions, but there was a sort of a question in the chat, and so I think this can sort of join with that. Is some of the work that you're doing looking at trying to either neuroprotect or to restore retinal ganglion cells? Is it either informed by, or do you think it will inform restorative therapies for other eye diseases, such as for photoreceptor regeneration or retinal pigment cell regeneration for maybe patients who have inherited retinal diseases or AMD.
Yeah, and I think, I belong to a niche group of ganglion cell people, but obviously induced pluripotent cells or stem cells are something that everybody in the eye field is currently working on, whether there is transplantation with RPE, clinical trials with RPE, iPSC-derived RPE, or photoreceptors. And so I think whenever we all get together, even at these conferences, that's our whole goal, right? Like, how do we join up ideas from different scientists and take it to the next level? When we are making many retinas in the lab, we go about 35 to 40 days, and then by then the ganglion cells, that's our sweet spot. But I have grown mini retinas in the lab for 600 days, right? Practically. And my postdoc work was in Dr. Bud Tucker's lab. And so there, I used to do inherited retinal eye diseases. So, a rare form, which is TRNT1 associated, RP. And so in that, I used to solely work with photoreceptors. And so, yes, there is a lot of translational value between fields as well. And, a neuroprotection drug can also be taken to the next stage in neurodegenerative diseases as well. Because one unique aspect of the eye is that it's part of the central nervous system. We don't have access to the brain, but we have access to the eye. We can do intravitreal injections, things like that. So something that you're developing in the lab for one retinal neuron could be potentially translated to other neurons that are terminally differentiated and have that potential. In fact, one of the aspects we are doing in our lab is there are patients with Alzheimer's and glaucoma, or Parkinson's and glaucoma. And there are multiple subtypes of retinal ganglion cells, approximately 20, even in the human, have been documented. And every ganglion cell has a different, task, or they're subgrouped into 4 major subtypes and 4 major types, but there's non-image forming or image forming, or that control circadian rhythms and different things like that. And so one unique aspect of these RGC subtypes is to identify what do they do, what their functional characteristic is, and what would be the best subtype to transplant as well. And so that, what we interestingly is other neurodegenerative diseases have certain subtypes that are dying easily, while glaucoma patients have one subtype dying. And it's a contrast. So when we add both the neurodegenerative diseases together, would there be a different phenotype that we'll see? And so definitely translatable, coming back to your question, to other ocular neurodegenerations or regular neurodegenerations as well.
And that's interesting. I didn't actually realize that some other neurodegenerative diseases like Alzheimer's or Parkinson's also have impacts on the retinal ganglion cells.
Right, yes.
Morgan, I'm going to call to you because I think you're the holder of the questions, if any have come in.
Yes, we have lots of questions. So let's see. There's a couple that are specific here to Dr. Sharma's work. So in the Q&A, Cameron has said that they have closed angle glaucoma and is asking, what's the timeline for this research that's taking place in Dr. Sharma's lab, both on regeneration and transplant, to come to market for the general public? So maybe where are you in that stage, and sort of where are you hoping that that's going to go to?
Yeah, so we currently, obviously, we are trying to study what the trophic factor is doing. We just recently got an NIH R01. And so we're using that to not only understand, so we are doing preclinical work at this stage, but the preclinical work mainly involves human donor tissue so that we can see how the human donor eye is getting affected. And so that has a little bit more translational relevance. The grant is for 5 years. Our next step would be making nanoparticles out of this drug, slower release drug formulations, trying to see if we can do at the end, can we take it to more chronic glaucoma models in the animal sense, but also hopefully in the near future, maybe within my lifetime at least, to trial clinical trials for sure.
And one of the other questions that we'd had come in by email was something similar. From Brian was asking if you know, is there anyone like anywhere else in the world that's doing stem cell research on glaucoma, but with human trials at this point, or is it all preclinical and animal models?
The preclinical animal models, there's certain trophic factors that are in clinical trials, but stem cell strategies are, they're more in the photoreceptor field or the RPE field.
Thank you. And then the last question that we have here is asking from Ruth, is asking if the research that you're doing could also apply to other eye conditions that damage the optic nerve. I know you mentioned some of the retinal, but other optic nerve conditions, would those be more directly linked to your work?
Yeah, so if, you know, it depends what part of the optic, like if you're talking about the retinal neurons, yes, that's our goal. So the retinal ganglion cells that are making the optic nerve. But if it's a gliosis related kind of disease, we are not touching on the gliosis, but like oligodendrocytes or things like that. So other cell types could be present in the optic nerve. But if it is truly damaging the optic nerve and it's an optic nerve neurodegeneration that is affected, that is part of the retinal ganglion cells, yes, that's our hope or aim.
Great, thank you so much, Dr. Sharma. It was very nice to hear from you and very exciting to learn more about your research.
Thank you so much. Thank you for inviting me also too.
I'm going to invite Dr. Jinapriya to come on now. I'm going to give you a spotlight. And come on as well. There we are. So we're going to be joined now by our second guest today. Dr. Delan Jinapriya is a assistant professor at Queen's University, director of the Queen's Glaucoma Fellowship Program, and the medical director of the Galen Eye Center. He's an executive member of the Canadian Glaucoma Society and serves as an advisor to Ontario Health Technology Assessment Program, which helps develop determine the value of new technologies and whether they should be funded by Ontario's provincial health plan. After becoming an ophthalmologist, he has made it his mission to reduce preventable vision loss and has been trying to achieve this through providing a large volume of clinical care, being an educator of future eye doctors, and by finding ways to improve the systems and processes of healthcare delivery. So welcome, Dr. Jinapriya. Thank you so much for joining us.
Thank you for the invitation. Happy to be here.
So we called this webinar Glaucoma in Research and Practice, and we've talked a bit about the research. So I want to talk now about the practice, about being in the clinic and what that looks like for people who are actually living with glaucoma. So for everyone out there, again, feel free to please ask your questions. You can do so by typing them in the Q&A box or by emailing me at education@fightingblindness.ca. I have quite a bunch of questions already that have come in. So we're going to dive into those, but I thought before we did, we could just back up a wee bit. And I was hoping, Dr. Jinapriya, you could help kind of set the stage by giving us a very brief description of how glaucoma affects the eye, just maybe a minute or two.
Sure, absolutely. Can I share a slide? Would that be possible? Can I share a screen?
Yes, I think so. Let me make sure you have that permission.
Yeah, it's right now disabled if you could.
You can definitely do it now. I just asked that for the members of our audience who may not be able to see it very well that you describe it. But you should be able to.
Good point. Okay, so what I'm going to do is share a slide with you. 1 second here. And this is an anatomy slide. I just want to make sure that that we just get our bearings on our anatomy. So there's a question about, is there a difference between cataracts and glaucoma? And the answer is yes, there is. So right now I'm going to show you. So do you see an eye in front of you? And what I'm showing here is the front part of the eye. There's a clear windshield that we call the cornea. And then light will go through that cornea, and there's a black hole in the center of the colored part of your eye, and that's what we call a pupil. And sitting behind that is a lens. And that lens will then focus light onto the retina. And that's what we've just heard about for the last half an hour, is this retina and these ganglion cells that are within this retina that collect all those light signals and transmit it to your brain through this big cable or nerve called the optic nerve. And so then the brain does all the processing, but it has to receive information in order to process. And so That's where the optic nerve comes in. That's where the retina and the ganglion cells come in. Now, this lens up at the front is actually what develops into a cataract, okay? So when this becomes older, when the lens becomes older over time, or discolored from whatever, it might be UV light, it might be medications, it could be other types of toxins, then light will find it more difficult to pass through this lens, and that's what we call a cataract. Now, the glaucoma is when you see pressure happen within the eye, and it actually ends up damaging these retinal ganglion cells, and as a consequence, we end up seeing a loss or a thinning out of the overall thickness of the optic nerve, because those ganglion cells have long tails that are, that are going down and forming this big cable. And so if you lose the ganglion cells, you're also going to lose these cables. And so you see a thinning out of the optic nerve, and there's less information that'll make its way to the brain. So I'm just going to stop my share there. And glaucoma, therefore, is going to be this loss of vision. Do you guys, have I stopped sharing with you? Okay, you know what? I'm going to go back to sharing. There's one more thing I want to show you. Okay, so let's go to here. Do you see my laser pointer on the image?
Yes.
Okay, this is a very healthy optic nerve, and this shows us normal looking blood vessels, and what you're seeing here is a very thick amount of tissue. You're going to contrast that with this picture here, which is a very thinned out tissue and a hollowing. There's no tissue in the middle here, and so we have lost nerve tissue in this eye, and this is glaucoma. Now, simplistically, what you've heard is that glaucoma will affect people by, if this is normal, you'll lose your peripheral vision, right? Until you're left with this tunnel of vision. When we do visual field tests, for those who have done them, which I haven't met anyone who likes to do them, but the reason we do them is that the eye is very good at hiding visual field defects for those who are actually looking out through their own eyes, but we can catch the visual field defects, and they'll look something like this. And you can see how this has become a larger visual field defect than the one on this side. And now you can see that it's come into the bottom half as well. And you can see that it's thickened in both the top and the bottom half. And so this might be a more practical visual experience. But the reality is, you would expect with somebody who has glaucoma and both eyes open, and they have these visual field defects, that they would be seeing these, or not seeing these areas in their vision that are missing. But the reality is people actually see this, because the brain does not like to actually have black areas. So it fills it in with what it believes should be there. So you can see that this person is the type of person who's going to say, well, I see pretty well, like I can see what I need to see, but the reality is down below, they can't see down here. And the brain has just put in place what it believes should be there, when in reality, what's going to end up happening is there might have been some shoes or a carpet or something like that. And so, or a curb. And this is where you have an increased incidence of falls and fractures in people who have glaucoma. So that's, from a practical vision experience standpoint, that's what we find happens for people with glaucoma. Is that a good enough starting point? I'll maybe stop there and stop my share.
A great place to start. And now we can ask a few of the questions. So we've got lots of questions that have come in by email and lots of questions from here. So let's sort of start with this question from Elizabeth. Elizabeth is saying, my pressures are very controlled by drops, but I'm still showing damage. And then she says retinal with a question mark on her visual field tests. It's getting worse year by year, and I don't understand why.
Okay, well, first, the question, we have to bear in mind that glaucoma is one form in the way that you can actually lose your visual fields. But if there's something happening with your retinas, your maculas, for example, or with the blood vessels themselves that are feeding the neural tissues, that can also, unfortunately, cause visual fields to progress. However, let's just assume that what we're dealing with here is only glaucoma and the rest of the eye is normal, in the sense that the retina is normal, there's no macular degeneration, and there's no blood vessel conditions like diabetes, okay? Under those circumstances, what we have to ask ourselves is, do we have the correct diagnosis of glaucoma? Somebody has brought up narrow angle glaucoma versus open angle glaucoma. If you are trying to treat open angle glaucoma, or if you're trying to treat narrow angle glaucoma as if it is open angle glaucoma, you will see progression, because what you will treat is the number. You will treat the pressure that is read in the clinic, when the reality is you haven't gotten to the heart of the matter, which is the fact that the drainage system isn't open. And so there'll be times of the day where the iris will dilate. For example, in the evening, it will dilate and it'll rest on the drainage system, and it will cause a transient increase in pressure. Okay, so these intermittent spikes in pressure can cause a progression of glaucoma. That's one possibility. The other possibility, though, is medications. People are on anti-hypertension medications, so on blood pressure medications. If your blood pressure is too well controlled and you have low blood pressure, you're at risk of not having enough blood flow to the very far periphery, to those very small vessels, which happen to be those small vessels that are actually feeding your optic nerve. So we can see glaucoma progression or apparent glaucoma progression in those who have low blood pressure. Okay. And so sometimes what we'll have to do is we'll run a 24-hour blood pressure on people. We'll see how low their blood pressure goes. And if it is hitting a very low point, which typically if it is, it's going to happen at night while they're sleeping, we'll ask whether their drugs can be modified such that they take their blood pressure medications in the morning, or perhaps their doses are altered such that they don't have those nighttime dips in blood pressure. That's another possibility. I would say I'm going to leave it at that in terms of the progression. I mean, the other possibility here is, look, you know, depending on how advanced the glaucoma is, we're all losing some neural tissue and we're all losing some visual functioning over time. So aging is happening. Every part of the body is not functioning as well after the age of 21. Okay. And if you have very advanced glaucoma, unfortunately, what can happen is you can actually perceive the changes, or we can see the changes that are happening with aging. Now, the reality is that that would be the outside answer. And I would put that much further down on the list as to why somebody appears to be getting worse in their visual fields or in their glaucoma, despite the fact that their pressures are well controlled. I would look to, are there other conditions? Do we have the right diagnosis of glaucoma? Do we have any blood flow issues? So in other words, do we have any blood pressure issues that we need to manage? And are there any other conditions in the eye that can also be affecting this, like the cornea? Is the cornea swelling at all? Is there a cataract that is developing? All those things can also make your visual fields appear to worsen. Okay.
Thank you. We have another question here from Wendy. Wendy's from Manitoulin, and she says, I have open-ended glaucoma and have been referred to have filtering surgery. What does this entail?
Okay. Filtering surgery is a broad term, which means that we're going to bypass the body's natural drainage system. Okay. Now, you can do this in several different ways now, thankfully. We used to be limited to 1 or 2 ways if you go back 20 years, and now we have maybe 8 ways. You can either make the existing drain, you can put a device into the existing drain or into the wall of the existing drain and make the existing drain function better. That's the most minimally invasive form of filtering surgery. Okay. The more advanced form and the more aggressive way and the lower pressuring way is going to be to bypass the existing drain. And that can be done by either a very traditional surgery called a trabeculectomy, or it can be done by newer surgeries where we implant devices which act as conduits from the inside of the eye to the outside of the eye to allow fluid to leave from the inside of the eye to the outside of the eye. And there are a variety of different devices that can do this. Okay. And some of them are less invasive than others. And by and large, that's the direction that we now go in, with trabeculectomy less favored because it comes with a higher complication rate. Great surgery, can get some fantastic outcomes, but the postoperative period, the 8 weeks after surgery, are a little bit more complex and involved in trabeculectomy surgery compared to some of these other implants that we are currently putting into people's eyes to lower pressure for filtering surgery.
On that note, we had a question about trabeculectomy surgery, and they're asking what is the success rate for this type of surgery, and they mentioned that their pressures are 19 and 23 at the moment.
Mm-hmm. The success rate is probably around, and it depends. It's going to depend on the individual. If the younger the person, the higher their chance of failure. It also depends on whether there's any propensity towards scarring. But let's just say, broadly speaking, you're looking at about a 75% success rate. And by 75% success rate, I mean that you will have a pressure of somewhere between 10 and 14 without drops. That would be considered successful. Okay. So that's the answer to the trabeculectomy question.
This isn't in the questions, but just hearing you talk about these different options for surgery, how, as a doctor, or what advice would you have for a patient who's kind of weighing these options? Because it sounds quite complicated. Like, how do you sort out what is the best treatment modality for a patient?
Right. Well, that's not an easy answer. And the reason that's not an easy answer is not every center has access to all of the options. Okay. So you have to essentially have the surgeon who you're with be comfortable with the surgeries that they're doing, right? So you'd probably, every surgeon has some tools in their toolbox, and that's going to be part of what makes your decisions. I mean, if that surgeon has tools A, B, and C, well, you're not going to ask for tool D and E, right? You're going to have to work with tools A, B, and C. Now, after that, if the surgeon has access to everything, there are a lot of factors that have to be taken into account. One is, how much pressure lowering do you really need, right? If you're trying to bring somebody down to, and all you need to bring them down to is 16, you have a lot more options and safer options than if you need to bring somebody down to 10 or 12. Okay. So it then depends on how advanced somebody's glaucoma is. If somebody has advanced glaucoma, you're aiming for 10 to 12. And so you need a more powerful surgery. So you need the trabeculectomy. You need a Zen implant. You need a PreserFlow implant. You need an Ahmed valve implant, a Behrveld implant. You need one of these types of surgeries to be done for you. Okay. If you needed a pressure of only 16 or 18, because maybe you have early glaucoma and right now your pressures are 25 or 26, and you just need to get you to the high teens, and that would probably hold things. Well, then you can look at eye stents, you can look at hydrus, you can look at something called GAT. So it depends. It really does depend on how much pressure lowering you need. And then there are some other factors. How old is the person? If we're dealing with somebody in their late 80s to early 90s, you would put in a device that maybe had a flow restrictor on it so the pressure doesn't go too low. Okay. So these are all the things that I at least take into consideration when I'm selecting what type of surgery I'm going to be doing. And also how capable is this person of coming for follow-up? If you're going to have a surgery that is going to give you a very good pressure lowering, you need a lot of follow-up. The first 8 weeks are really critical. The surgery is not necessarily the hard part. The hard part is the ensuing 8 weeks where your body is trying to heal and your surgeon is trying to figure out, is this an aggressive healer or is this not an aggressive healer? And do I increase their drops, their anti-scarring drops, or do I decrease them? Do I maybe go in and break away a little bit of scar tissue? I can see that their pressures are rising a little bit, and do I alter the course? Those are all the decisions that have to happen in those 8 weeks. So there's a lot of effort on behalf of the person who's having surgery, as well as the surgeon, in order to ensure that there's a great outcome at month 2 to 3.
Thank you for answering that. So obviously, I guess, a lot of people will be taking drops, kind of the first line treatment for glaucoma in many cases. And Evan's asking, so if they have glaucoma and they're taking their drops, but is there anything else they can do to help prevent further damage and vision loss?
From glaucoma, right? Look, at this time, and that would be a great, actually, I'm curious to know whether Dr. Sharma has any kind of anecdotal evidence or anything like this to suggest that there are things that we can do in our lifestyles that are neuroprotective. But while she's thinking about that, I will say this. Look, the ocular blood flow is important, right? And so ocular blood flow is going to be dependent upon your cardiovascular status. It's going to be dependent upon your lipid profile, meaning your cholesterol status and your blood pressure, right? So let's just lump all of that into your cardiovascular status. The more cardiovascularly fit you are, the better in general it's going to be, not just for your eyes, but for the entirety of your body, including your brain, right? That's issue number one that you can control. Number two, interestingly, that may or may not be within your control, but you know, it could be if you put effort into it, is stress management, meditation. Very interesting study out of Boston, which took people who did not know how to meditate. They took one group of people and they said, hey, take 20 minutes and just do whatever you want for 20 minutes that's quiet and relaxing. And they took another group and they did guided meditation for 20 minutes. And then they looked at their pressures before and after a month of doing this. And the group that did the guided meditation was significantly down relative to their baseline. The other group, who also took 20 minutes to do whatever they wanted to do to relax, they didn't change their pressures. So there's something in that, whether it's cortisol levels, we're not really sure, okay? But there is something to do with the type of life that you're, you know, the stress that you're experiencing that can actually impact not just your eye pressures, but obviously your blood pressure and other things, right? So those are the two lifestyle factors that I would say are worth looking at. Dr. Sharma, I don't know if there's anything else that you've come across.
Yeah, there have been multiple reports on just like different kinds of vitamins, like vitamin C and vitamin B3. I know like omega-3 and 6 also, magnesium. So, you know, it all comes down to vitamin C acting like an antioxidant because there's oxidative stress going on, mitochondrial damage going on at the optic nerve head within these axons as well. I mean, magnesium has been linked with improving ocular blood flow, I feel. So there's been multiple studies with that. I know there has been like niacin, which is vitamin B3. I'm trying to think with primary open angle glaucoma as well, and low niacin or vitamin B3 has been linked with NTG, but there have been 1 or 2 reports on that. So I think sometimes supplements do help. I think definitely meditation, reducing your stress levels, you know, exercise, I think helps. And you know, even as we age is a big risk factor, right, for the disease. So when you age, you increase oxidative stress, you're increasing some of these factors. So helping taking some sorts of supplements always helps. Relaxation, increasing blood flow, stabilizing, you know, compounds. So I agree with that as well. Dr. Jinapriya. Mm-hmm.
Thank you. And actually, Dr. Sharma, while I have you, I noticed there is one other question in the chat for you. Does Neite protect Rgcs in models with different forms of glaucoma? So the examples given are hypertensive, normotensive, closed angle, etc.
Yeah, so we have only done it in hypertensive, but we've tried it in hypertensive chronic model, but our published data currently is only on acute model, so where we did the optic nerve crush. So it is an acute form of surgery, but our next goal, hopefully like an extension of the R01, would be to test it in different kinds of chronic glaucoma models. So either there's a lot of animal models out there like laser-induced ocular hypertension or, you know, the microbleed occlusion model, some more chronic forms of glaucoma right now. And for the normal tension, so we do that kind of in the lab in a way. So my perfusion human eye model system, we can put normal pressures and then put Neite, and we've seen protection. So as soon as we get the donor eyes, they're basically cut at the optic nerve. So once they're cut, the cell death has started, right? So as soon as the cell death has started, we can take these donor eyes and put it under normal pressures. And once we put it under normal pressures, we still see protection. So there's still survivability of these ganglion cells, even though there's exotomy at the optic nerve of the optic nerve.
Thank you, Dr. Sharma. I'm going to go to a couple questions from email, because we have a bunch. For Dr. Jinapriya, Walshwood asks, they said that their glaucoma was diagnosed a few years after receiving Lucentis injections for AMD, wet AMD. Would stopping the injections, this is not that I intend to, but would the stopping those injections reverse the glaucoma?
The short answer is no. Glaucoma damage means that the nerve has been damaged. And if it's truly glaucoma and the nerve has been damaged, as we've heard, at this time, we're not yet able to regenerate that, although clearly there are attempts, and I'm sure soon we will be able to do that. But at this time, the answer is if glaucoma damage has happened, no, it can't be undone. If what they meant by glaucoma is you have high pressure, okay, maybe no longer injecting will alleviate the high pressure, but that's, why did you have high pressure when they injected you? The system should have had enough capacity to deal with the injection and to adjust and not have that high pressure. So there's something that it's almost revealed that there is this high risk for glaucoma in your eye, right? So, but the bottom line is no. If this has happened during the intravitreal injections, then this needs to be followed further and managed. And glaucoma is certainly a concern going forward.
Thank you. Our next question is from Hedrom, and they're asking if an individual who has both eyes affected by glaucoma is asking, why does one of the eyes shrink while the other eye still looks full? Does that make sense? I think I'm reading that correctly.
Yeah, it's not usually that an eye is shrinking or one is growing. What it is that the lid has changed. So if I was to do this, you'd think that one eye looked a little bit smaller than the other eye, but what's happened is my lid has dropped. So the question then would be, is one eye receiving different medications than the other eye? Has one eye had surgery and the other eye hasn't? Those are the things to consider in terms of why the eyes might look different. But realistically, if we were to measure the eyeballs themselves, which we do, we have to do that when we're doing cataract surgery, we don't see a change in the size of the eyeball despite having glaucoma, unless you're a child. That's the caveat to that. But for the majority of people who are here today, it's going to be adult glaucoma that we're dealing with.
And in terms of appearance, I've heard that certain drops can actually change the color of the eye. Is that true?
Can change the color of the iris. So our number one class of medication is called prostaglandin analogs. And, there are a few brands and molecules within this class of medication, and they're highly effective. They're once a day. They're really well tolerated with no side effects, allergies, let's say, no allergies and no systemic side effects. But in about 10% of people, it'll change the color of an iris from, let's say, hazel to brown. If it's really blue and there aren't any pigment granules within the iris, it's not going to change it. So there have to be some pigment granules. If you've got a brown iris, it's going to become potentially even browner, right? So that's what would happen with these prostaglandin analogs. Yeah. It can also, in some people, change the color of the skin. It can become darker. When you stop the drop, the skin change will go away, but your iris change will not go away.
Very interesting. Gosh, we have so many questions and I know we're running out of time. Let's see. We have a question here from Stephanie. So she said, I have closed angle glaucoma in both eyes and my visual acuity is 20/200, but my visual fields show that my visual field is greater than 20 degrees. My eye doctor says that I am not legally blind as a result. Does your visual field also need to be less than 20 degrees to be considered legally blind in Canada?
No, it's one or the other. So less than 10 degrees counts. So you could have 20/20 vision and a 10-degree field, And that would count as legally blind because you're missing like 95% of your visual field, right? 95% of your vision is missing. The part that you have is great. You could have 2200 vision, which means you've got a lot of vision. You've got 20 degrees of field, but the quality or the resolution within that vision isn't good enough. It's lower than a certain amount, right? It's lower than the driving line anyway, right? So that would also count. I'm pretty sure 2200 is that cutoff. So yeah, so it doesn't have to be both. It's one or the other. I just want to, I saw something in the chat about somebody asking about symptoms of glaucoma and whether they should be checked. And they had been told they had a thicker optic nerve.
Oh yeah, I have that one here. Let me read that for you. Daniel, he says, I was told by an optometrist that I have a thick optic nerve. Is this the one that you were thinking of? Yeah.
It is.
He said, I'm assuming she was referring to my optic disc and I need to get tested for glaucoma. It's been 8 years since then and I have no symptoms of glaucoma. Should I still get checked? This is FYI, my maternal grandmother has glaucoma and Alzheimer's.
Yeah, okay. The answer is absolutely yes, you should get checked. And the reason is glaucoma has no symptoms. There's going to be the occasional person out, who has symptoms and they have an aching eye or they present one night to the emerge vomiting from eye pressure. That's rare. Not even 99. 399 out of 400 people have no symptoms. And when they have symptoms, they're down to their last 5% of vision, right? Because the brain is so good at filling in all those areas that it's missing. It happens so slowly that the brain accommodates and it just fills in those areas with what it thinks should be there. So people do not perceive a problem, right? And even for those with relatively high pressures, the eye adjusts. It's shocking that some people can come in with pressures of 40 and they have no symptoms. They don't feel anything in their eyes. So don't wait for symptoms. Glaucoma should be diagnosed based on a great clinical exam. And there's plenty of diagnostics we can do right now that you could have the diagnostics done and it could have been read by a number of people online anywhere to tell you the answer. Right? They might not be able to tell you what type of glaucoma you have. Like within open angle, there's a variety of open angle glaucoma. So you'd need a clinical exam. But we can certainly tell if somebody has retinal nerve damage. That we can tell, right? So yes, you should definitely get evaluated.
Thank you. Yeah, I think that's a very, very important point. And it's funny, I'm 40 years old and I went to the doctor this year and I have a very high myopia, so I have a very strong prescription, and they did my test and they put me on glaucoma drops and I'm like, I'm 40, this can't be a thing. But because I have such a thin retina from my myopia, that there's the pressure in my eye, even though it may be normal for someone who has a thicker like structures in their eye, is not necessarily normal for me. So and I had no idea, right? You have no idea of going in. So it's so important to get those checks and get all those tests when you go to the eye doctor, to check the pressure, to check the retina. I know how many people hate getting those dilating drops when they go, but it's so important because there's things in there that you wouldn't know until it's too late. So I really appreciate you reminding us all that we need to get those checks.
Yes, thank you so much for bringing that up. And thank you so much for bringing up the fact that your pressures really were not that alarming.
Yeah.
And yet your practitioner said, look, you need to lower your pressures. Glaucoma is not about the pressure. In fact, if you look at the definition of glaucoma and its evolution over the last 2 decades, we have removed that part of saying, oh, it is a pressure related condition. It's not. There's some people who have very normal pressures and their nerve is dying, just like a Parkinson's, right? There's something wrong with the neural tissue. The one thing we can do to help it, though, and to slow it down, is take the stress off of it. So we take some pressure off of it. But that's not really the problem in those people. There are others for whom, yes, it's all pressure related. It's like you can take the healthiest leg in the world and tie a tourniquet around it. And of course, the bottom part is going to be devoid of blood and it's going to atrophy and you're going to lose your leg, right? But that was a healthy leg to begin with. That's a very different circumstance than somebody who's losing muscle tissue for no good reason, right? That you can identify. Anyway, So glaucoma is not just about pressure. If somebody says, oh, your pressures are normal, you don't have glaucoma. Either they've simplified it a lot for you and you should dig a little deeper, but glaucoma is a diagnosis based on whether you are losing neural tissue or not. That's what it's about. Okay. So just bear that one in mind as well as you're thinking about glaucoma and what your eye doctor should be talking to you about. Laser.
Well, I realize we're at the end of time, but I was actually just going to ask you that last question. So there was someone in here who said that they're 71, they have advanced open angle glaucoma, their pressure is 9 to 10, and that was done by laser, which you haven't mentioned. So do you want to just comment on laser before we wrap things up?
Yes. The way I'd look at lowering pressure, there are 3 ways, right? There's drops, laser, and surgery. And it's not necessarily in that order. Okay. It used to always be in that order. Now it could be laser or drops. It might even be, as we become more and more minimally invasive, that you could go for a minimally invasive as a first option. We're still probably not going to do that. We're still probably going to suggest laser or drops before you do even something minimally invasive. On the aggressive side, on lasers can be mild or they can be aggressive. All right. So there's a spectrum of laser treatment that we have to offer. And again, this is a tool that might be in some people's toolbox or not. It is a tool that I will use either as a gentle treatment, meaning instead of using a drop or instead of adding an additional drop, or here's somebody who is too frail to undergo surgery. They cannot come back for a lot of follow-ups. We're going to do a laser, which we do in the operating room, and we apply it. It only takes 40 seconds, and it turns the tap off in the eye. So it's effectively damaging the tissue in the eye that produces fluid in the eye, which turns the tap off, as opposed to everything else, which is increasing outflow, increasing your drainage. This turns the tap off and the pressure will come down. So that's another way that you can lower pressure. All of these things have pros and cons, right? And they all have to be discussed with you, and their individual risks depending on whatever background conditions might also exist within the eye.
Great, thank you so much. And thank you to everyone out there who has been asking all these fantastic questions. I'm sorry we weren't able to get to everything, but I have put in the chat the email address for our health information line, which is healthinfo@fightingblindness.ca. So if you have questions today that weren't answered, please feel free to reach out to me there, and we'll try to help get you the answers and resources that you need. So again, I want to thank Dr. Sharma and Dr. Jinapriya for joining me today and for sharing your time and your expertise. It's been really lovely chatting with you both.